Okay. Hello, my name is Deborah Cohen, and I am the MAVEN volunteer moderator for today's session, which is Menopause, a Primary Care Approach by Doctors Carrie, Horwitch, and Betsy Strong. I'd like to tell you a little bit about both of those after mentioning that the Cherokee Health Systems is our anchor clinic today. Dr. Carrie Horwitch is an outpatient primary care physician in practice for over 30 years. She is also a certified specialist in care for patients living with HIV. For 20 years, she worked with the Virginia Mason Medical Center Internal Medicine Residency Program as an associate program director. She's a clinical associate professor of medicine at University of Washington, Seattle, as well as a member of the Board of Trustees for Washington State Medical Association. Dr. Betsy Strong was a general internist and primary care physician for Palo Alto Medical Foundation in Sunnyvale for 26 years, Sunnyvale, California. She dealt with acute and chronic medical illnesses, as well as women's health and geriatrics. She continues to be active in Palo Alto Medical Foundation's Women's MD Group and Internal Medicine Journal Club, as well as volunteering for MAVEN. And with that, you all can please begin.
Great. Thank you so much, Dr. Cohen. As it was mentioned, neither of us have any disclosures. You've already heard about our CME accreditation. Just a couple quick points. These are our emails. If anybody would like to contact us, it will also be in the recording that you will get. I do want to specifically say that we are not gynecologists or endocrinologists. We are both predominantly outpatient primary care internal medicine physicians. I also want to point out that none of our discussion today is about gender-affirming hormones or even hormone use in the trans male persons. We did take some slides from several talks from American College of Physicians meetings from Doctors Kling, Merriam, and McNeil. And those are identified by having a little lamp, oil lamp in the corner. So those will all be from the ACP. Next slide, please. So what we're going to do today is we're going to talk about what is the diagnosis of perimenopause and menopause, talk about some of the common symptoms of both of these conditions, talk a little bit about the benefits and the risks of menopausal hormone therapy, both systemic and vaginal. And we will also talk about some of the benefits and risks of some non-hormonal management of these symptoms. Next slide. So by definition, menopause is when a woman has not had a menstrual period in 12 months. And that is not related to medications such as birth control, surgery, or any other interventions. Perimenopause is typically the time that leads up to menopause. And it's when the menses may start to become irregular. Again, if there is bleeding, I really want to point out that heavy bleeding or abnormal bleeding, even during this time frame, don't just assume it's perimenopause. It still needs to be worked up with appropriate workup for abnormal vaginal bleeding. But vasomotor changes can start several years before true menopause, and it is really variable across the spectrum. I have had women have no problems go into menopause and then have symptoms, and others have several years while they're still having periods before they actually are truly in menopause. The average age of menopause is about 51, but again, the range is in the 40s to even late 50s. Premature menopause, previously called premature ovarian failure, is any menopause that is before age 40 and could, again, be biologic, it could be hormonal related, it could be surgically related, and it may need additional workup. Next slide. So as we talked about some of the stages, we have the early menopausal, and again, there may be varying length of menopause. It may be shorter periods, it may be longer periods, it may be less time in between, it may be more time in between. It's, again, there is no consistent pattern for any group of people. It is all individual. Late menopause is when you do start getting longer periods without menses. And please, by all means, make sure you check pregnancy tests during that because that is a common cause of amenorrhea even in this age group. Vasomotor symptoms, if women are going to get them, typically starts then. 5 years after you start having some of the menopause or the menstrual period changes, you will start to be in early postmenopause. Vasomotor symptoms tend to become most problematic during this phase. And then late postmenopause is considered 5 years after finishing your last menstrual period. And then you may start to get some of the genitourinary issues such as vaginal atrophy. Next slide. Just a couple more characteristics. Again, the vasomotor symptoms can last, again, average maybe 7 years, but it really is variable. I do have some women or had women who had persistent symptoms for years, which is more unusual, but quite bothersome to them. The genitourinary syndrome of menopause we spoke about, and we'll talk a little bit more about that later. But that could be urinary symptoms, but a lot of times it's more dyspareunia or pain with intercourse or vaginal atrophy. Sleep disturbance, and that could be separate from the vasomotor, but the vasomotor symptoms can also cause disruption of sleep, is quite common. Mood and cognitive disturbances, some people will say, I'm just not thinking correctly. So, I can't remember, I'm forgetting names. So again, obviously you would still want to make sure you're doing an assessment for any other cause of that, but menopause alone can also cause some of those. Depression and mood changes can occur in several patients. It tends to be more common in people who have had prior anxiety or specifically more depression during that time. And then, of course, sexual dysfunction or, again, loss of libido can occur as well. Next slide. And other changes, just to mention, the thinning of the hair, the dryness of the skin are also common concerns. Joint aches or pains, some women also state during this time frame. So one of the questions we're always asked is, well, I need a lab test to diagnose menopause. So should I get my hormones checked, as a lot of patients say? And I want to just emphasize that perimenopause and menopause are clinical diagnoses. There is actually no consistent test that is going to tell you that somebody is in menopause because the FSH and LH labs are really variable throughout the menstrual cycle and even in the menopausal. And again, they will also vary if somebody is on birth control or even menopausal hormone therapies. However, if you have someone with premature menopause, it may be reasonable to start checking levels to see if there's some other cause for that. But it's mostly not to diagnose menopause. It really is to make sure you're not missing something else. Pregnancy test is really important, again, as I mentioned. And a thyroid test is also a test I do a lot because hot flashes, sweating, confusion, or mental, memory things could also be a thyroid condition. So I usually do check that on women as well. Next slide, please. So menopause is a clinical diagnosis. And again, as I mentioned, you usually do not need to do any labs in preparation, especially if a woman's over 45 years and it fits. I have very low threshold for pregnancy, and I pretty much do it in anybody who comes in with amenorrhea. You may want to do labs again if there are menstrual disorders, if they've had current use of contraception, a hysterectomy or endometrial ablation. And then again, if there really are not typical symptoms, that it's just you may look for something else, maybe, prolactinoma or something else that could also cause menstrual irregularities. Next slide. If you do need to do any testing for some of these other things, you would want to check the FSH, and you might want to repeat it if you stop the hormone or contraception device or birth control pills. Estradiol levels, again, you want to check it after they are off their contraception. Prolactin may be considered to look for hyperprolactinemia. And then again, if there's any concern with an endometrial process or abnormality, you would probably want to engage your gynecologist and consider transvaginal ultrasound and an endometrial biopsy. Next slide. So the other question I get asked a lot is, well, should I treat menopause? And I do want to say that age-appropriate menopause is a natural, normal aging process. So I don't like calling or thinking menopause as a disease. It is not a disease. It is what happens to us women as we get older. It does not require treatment, but that does not mean that treatment may not be beneficial and may be very helpful to our patients. The most common bothersome symptoms are the vasomotor changes, and those are the hot flashes, the sweating, the hot and cold, the chills, the sleep changes, the mood, and then the vaginal dryness and discomfort. And again, for many women, the benefits can outweigh the risks, especially if it's early in their menopause and they are under age 60. And always treatment should be with shared decision-making to go over the benefits and the risks. And again, talking perhaps about other options besides hormones, if that's what a patient wants. Next slide. So why would we say, maybe we should be treating menopause? Because there are studies that show that untreated women, especially those who are having significant sleep deprivation and vasomotor, actually have higher healthcare utilization. And there were higher outpatient visits, and most of those visits were for the vasomotor symptoms. It also costs more. And again, that was looking at a cost difference between women who were on hormones or not of over $1,000. There was more work productivity loss because of days missed due to, again, a lot of the vasomotor symptoms that they were having. And 13% of women report at least one adverse work outcome due to these. And almost 11% state they missed work in the preceding 12 months because of this. And that is an estimated loss of 1.8 billion just due to symptoms related to menopause. And again, this is older data, 10 years old, but still it shows that there's a reason to be concerned and to talk to our women about this. Next slide. So let's start with a case. So a 39-year-old comes to clinic. She's having hot flashes. She has not had a menses for 4 months. She did her own home pregnancy test, which was negative. She has not had any surgeries, uterus or ovarian surgeries. She did have a prior pregnancy and has one child. Very bothered by the symptoms, has heard a lot of different information about hormones. And also it's noted that her mom stopped her menses at about age 42 with similar symptoms. So what should you do? Next slide. Well, this would be it by definition, assuming she is not pregnant, which you should check, that this is premature menopause. She, again, is lacking menses for 4 months. So again, not quite 12 months, but she's under age 40. And again, it could be natural, surgical, or hormonal. If there are no absolute contraindications to hormone therapy, there is probably more benefit to patients with premature menopause. And that is because of studies that have shown that if untreated, that many of these women have higher risk of coronary heart disease, clearly bone loss and osteoporosis, more genitourinary symptoms, more memory concerns, and actually overall mortality. And the references are listed underneath this. So the recommendation is actually to treat women with estrogen and progesterone if they have a uterus. And you need doses that are much closer to birth control pills or birth control than to menopausal hormone therapy, which is actually a much lower dose than we give for contraception. Next slide. So moving on to case 2. Jo is a 49-year-old woman. She's coming in because she's complaining of sweating and hot flashes. Again, her last menses was about 4 months ago, but it's been irregular for a couple of years. Again, a home pregnancy test was negative. She's having trouble sleeping. The hot flashes are bothersome. She's averaging 3 to 4 hot flashes at night. And it should be noted her grandmother had breast cancer at the age of 80. She does not have any history of venous thromboembolism, stroke, or coronary heart disease. And so the questions you might ask is, well, is she in menopause? Does she need labs? And should this be treated? And if so, how to treat? Next slide. Well, by definition, she's still in perimenopause because it has not been 12 months. She does not, quote unquote, need a hormone test. But again, I typically will get pregnancy and thyroid to make sure I'm not missing anything else. And then again, shared decision making, whether or not you want to treat her menopausal symptoms, which seem quite bothersome to her, and sharing about the benefits and risks of each. And then again, there's different tolerances, there's different types to talk about. If she's having a lot of genitourinary symptoms and just wants that treated, then just topical or vaginal hormonal is appropriate. And then we'll also mention a little bit later about some of the non-hormonal and the non-pharma options. Next slide. But before you do, and whether or not somebody should or could go on hormone therapy, and that's estrogen plus progesterone if they have a uterus. Absolute contraindications is if a woman has had personal history of breast cancer. If there is unexplained vaginal bleeding, that needs to be worked up first and should always be worked up before putting anybody on hormones. If someone's had a history of endometrial cancer, if somebody has had a history of stroke, coronary heart disease, or MI, any history of venous thromboembolism, or even an inherited high risk for thrombosis. Active liver disease. So again, I typically check a baseline liver test before initiating hormones. Serious gallbladder disease, which should again be evaluated and managed prior. Prolonged immobilization, and that's mostly because of the increased risk of thromboembolism. And then obviously you would not want to give it if they are pregnant. Some of those where you really want to discuss more of the shared decision-making is in those people who may have a higher risk breast cancer. And we've given you 2 links here to the different tools that you can check out. And again, there are guidelines that say at a certain level, you probably would not want to use hormone, but at lower risk, you could consider it. Again, you can use a risk calculator for coronary heart disease. And migraine alone is not a contraindication, but if somebody actually has stroke symptom migraine, then again, that may put them at much higher risk for a thromboembolism or a stroke type symptom. So you may want to think about not using hormones in those patients. Current smoker, again, is not an absolute contraindication, but just like any smoker given estrogen, you really want to try to do smoking cessation because the risk of side effects is actually higher in smokers. And then somebody who's got really significant hypertriglyceridemia. And again, the reason for that could be because of the coronary heart disease, but it's not entirely clear for that. Next slide. And Betsy.
Hi, I'm speaking a little bit about the history of the Women's Health Initiative study, which I know is based on statistics, and I don't want us to get too bogged down on statistics, but I think that this history is important because there's been a lot of change in the last 20 to 24 years. So the WHI was initiated in about 1997, and it was a large randomized controlled trial, RCT, of about 68,000 menopausal women aged 50 to 79 who were put on standard doses of estrogen and progesterone, and that is the conjugated equine estrogen plus medroxyprogesterone. Those are what you commonly know as Premarin and Provera. Or if they had just had hysterectomy, it would be the estrogen alone. And the study was terminated early after 5 to 7 years due to a finding of increased risk of breast cancer, heart disease, stroke, VTE, which is short for venous thromboembolism, in the treatment group compared to placebo. So since 2002, there was a major decline in prescriptions of hormone therapy. And I was practicing since in the Palo Alto group since 92. So we were prescribing hormone therapy quite liberally encouraging patients to even take it for prevention of heart disease and for stroke, as well as for osteoporosis. And suddenly in 2002, basically with these new findings, we stopped prescribing, and there were really no clear guidelines for 15 to 20 years. So the next couple of slides I want to show you shows the later follow-up of the WHI study and subgroup data analysis, which showed that there was actually a big difference in risk between the younger age group, which is 50 to 59. Those are the early menopausal group, compared with older age groups, 60 to 69, and also the group 70 and older, who were treated with menopausal hormone therapy. And that makes sense, right? Because you know that the older age groups are going to be kept getting more heart disease and stroke and dementia and so forth, even, you know, regardless of whether they're treated with hormone therapy or not. And the other funny thing they found out was that there's a difference in risk between those who are treated with the combination estrogen plus progesterone versus those treated with estrogen alone. So this led to new guidance that came out in the American, now called the North American Menopause Society, in 2017 and updated in 2022. And we base a lot of our recommendations from this guidance. So I just want to go to the next slide. And basically, it shows some of this is covered with the black in the corner, but what it is that we're looking here at the younger age group of 50 to 59. And these are women who are treated with the combination estrogen plus progesterone versus placebo in the first table. In the second table is estrogen alone versus placebo. And then the endpoints are coronary heart disease, stroke, DVT, and PE, breast cancer, and mortality from any cause. So you could see here that in the red, this shows the increased risk, the number of extra cases per 10,000 patient years. So very quickly, patient years means that this is just an example would be 1,000 women treated over 10 years is an example. And then the hazard ratio, which is basically a relative risk. It's the same thing as saying, you know, this patient who's treated with the combo has 3 times the risk of having a DVT compared to someone who was not treated with placebo. And then the estrogen alone group is in the green here with one. The green shows that there's actually a lower risk, surprisingly, but there's one that is a higher risk, which is 1.66 higher risk of DVT in the estrogen alone group. So this hopefully is a little bit clearer in the next slide, which is another way of looking at the same subgroup analysis. It is taking now 1,000 women followed over 5 years and looking at the same endpoints that we just mentioned. So these numbers are effectively the same as the last page, but half. And the investigators were surprised to find out that there was a reduction of breast cancer in the estrogen alone group, and the experts say this warrants further study. And by the way, the risk of hip fractures, which is not included in these tables, was reduced in both groups. And it therefore led to the recommendation of considering hormone therapy for prevention of osteoporosis, especially if the woman is suffering from vasomotor symptoms. And if you need more detailed tables, please look at the last reference that we have from JAMA 2024, which is a review of all of this data by the original author, who is honed in the small print there. Manson, excuse me. Next slide. So case 2, we talked about the menopausal woman, early menopausal woman who was concerned about the side effects of hormones. And now she's heard about bioidentical hormones or herbal therapy, and she wonders if these are okay. And are there any other options? Next slide. So there are alternatives, and that bioidentical hormones are not recommended due to just very little data regarding benefit or safety. And so it's not only is it not FDA approved, but there's no standardization of compounded preps. There's no standardization of the mode of administration, nor of the tests that are used to monitor levels. So there might be use of saliva and urine, as well as blood tests to monitor levels. There's no monitoring of adverse effects and no labeling even of the product as to possible risk. So it is really considered the wild, wild west of prescribing, but yet it's a booming industry and it's very profitable. So patient education is crucial here. And then secondly, there's no consistent data regarding the benefit or safety of herbals such as black cohosh, primrose, dong quai, and red clover. And Carrie said in the last talk that when she had a patient who had liver toxicity from using dong quai on her own. And so let me just back up here and mention that when you query patients about their medications, and don't forget to ask them about supplements and vitamins, because a lot of patients do not consider these as medications. Lastly, there's variable data regarding soy, like tofu and so forth, to treat vasomotor symptoms, but it seems to be helpful. However, it's unknown as to the type or the amount of soy. Next slide. So acupuncture has variable data, and Carrie brought a couple of slides here that you can look at, which are systematic reviews of the safety and efficacy. And the American Menopause Society mentioned also that stress reduction, therapy, behavioral therapy, especially if there's associated anxiety and depression, would be useful. Weight loss, if indicated for obesity, would be helpful. Next slide. Other medications would be SSRIs like citalopram, SNRIs like venlafaxine, and data shows that these can reduce vasomotor symptoms and would be particularly useful if the patient also had mood issues. These are often combined with menopausal hormone therapy. Gabapentin has been used as well, but due to side effects of drowsiness and slight confusion, the dose should be started low, for example, 100 milligrams at bedtime, and slowly titrated upward if tolerated, if it's helpful. Next slide. So new class of medications are called neurokinin blockers, and they affect thermal or heat regulation in the hypothalamus. So this first one, fezolinetant, was recently approved, and some of my colleagues at PAM said it really helped their patients. But it's contraindicated in settings of liver or chronic liver kidney disease, and LFTs need to be followed for 3, 6, or 9 months or longer. Medication discontinued if they're elevated. It is not generic. It is expensive, about $500 a month, and it's not covered by insurance. Recently at JAMA, it published the results of a new study of a relative called elinezantant, which targets 2 NK receptors, and it apparently shows no adverse effect on liver enzymes. It's just been completed in phase 2 and 3, not yet FDA approved. Next slide. Okay. Case 2. The patient initially decided against hormones. She is now 51. Her menses stopped 13 months ago. Her hot flashes have increased, and there are no new medical issues. She's now considering hormone therapy. She has irritability, decreased sleep, vaginal discomfort. What are her options? Would she benefit from hormone therapy? Next slide. So indications for hormone therapy. Ideally, it'd be a menopausal woman less than age 60 or less than 10 years from the start of menopause. And this is based on our WH data, which I wanted to we mentioned earlier. And also no contraindications, no absolute contraindications, and discussion of the relative contraindications that Carrie mentioned. These women should have moderate to severe vasomotor symptoms, which can impact sleep and mood, genital urinary symptoms for those who also have vasomotor symptoms, and prevention of bone loss for those who are at risk, who also have vasomotor symptoms. And separately, genital urinary symptoms, if systemic symptoms are absent or mild, can be treated with vaginal estrogen alone. And so if systemic hormone therapy also is contraindicated, vaginal estrogen can be considered. And I just want to stop here and mention that not only does data come from the Women's Health Initiative, but also comes from the SWAN and Nurses Health Initiative. And Carrie put these references on the last page. And if you have any questions, I don't know if we mentioned earlier, please put them in the chat. And we may be going too fast. And if you have questions, just type them in and we'll address it at the end. Next slide. So hormone therapy options, you have systemic estrogen, and we're just going to talk about estrogen first here. For moderate to severe vasomotor symptoms, you've got topical patch that goes on the skin, oral, or a vaginal ring. And we're using more often 17-beta estradiol, which is close to intrinsic hormone. So when patients say they want the natural hormone, you mention to them, this is 17-beta estradiol, which is basically the same as what's produced by the body. You start with the lowest dose, for instance, estradiol oral 0.5 milligrams, or you can start with transderm, which is supposedly, it's apparently better because it avoids the first pass liver effect at 0.025 milligrams per day, which is 1 patch twice per week. And then after 6 weeks or so, if necessary, if symptoms persist, titrate up to the next higher dose. And that's actually the max. 1 milligram a day for estradiol and 0.05 milligrams a day for the patch. And these are available in generic. Oral conjugated equine estrogen, which is Premarin, is still prescribed and has, but Carrie will mention, has a slightly higher risk for VTE. Vaginal estrogen is for GMS or genital urinary symptoms when the vasomotor symptoms are absent or mild, as I mentioned earlier. And there's minimal systemic absorption. It can be started at any postmenopausal age, and it can be continued long-term. And be aware that there is a black box warning on the box, and it says that there is an increased risk of breast and uterine cancer, even though there is not such risk, and it may deter patients from starting. Next slide. Progesterone must be included for women who still have a uterus. It reduces the risk for endometrial hyperplasia that you would have with estrogen alone. Micronized progesterone, which is example is Prometrium, has lower side effects. And the cyclic can be used 200 milligrams a day for 12 days of the month, or daily 100 milligrams a day. Medication is typically given at bedtime due to possible sedation. And if you give the cyclic regimen, you would expect withdrawal bleeding. So this is a regimen that's often used for women who are newly menopausal, like in early menopause, because they're used to having cycles. Whereas you would expect amenorrhea due to atrophic lining in women who are given the continuous combined regimen with the daily dosing. And so the continuous combined regimen you might consider for someone who's in more the later menopause. They're now no longer used to having cycles, so amenorrhea would be welcome. And lastly, I should mention that progesterone is not needed if a woman is being treated with vaginal estrogen, because they've found that systemic levels are low due to minimal absorption. And there are combination pills. I know this is getting a little confusing because we're talking about estrogen and progesterone here, but I'm talking about combo, meaning estrogen and progesterone in the same pill or the patch. And I just want to mention a couple of examples. We're not promoting these name brands, but Prempro would be an example of a combo estrogen plus progesterone. The Climera patch would be an example of the combo that basically has the two together in the same regimen. And but if the patient's taking the two separately, like the transdermal patch and the Prometrium at night, make sure that the women do not forget to take the progesterone, because my gynecology partner said to tell me that that's happened, and that would be dangerous if they're forgetting to take the progesterone. Next slide. My last slide here, just mentioning some of the risks that Carrie had, so I'm not going to review them, and just side effects of estrogen are similar to that of progesterone. There could be breast tenderness, there could be headache, bloating, mood changes just from the hormones. And there may be uterine bleeding from the estrogen. There may be uterine bleeding from withdrawal of the progesterone. So those are side effects that patients should be made aware of. Next slide, and Carrie's taking it from here.
Thank you. Yeah, I just wanted to show a couple slides, and again, recognizing some of the data from WHI, there was a lot more use of conjugated equine estrogen. I think most of us are moving away from that and using estradiol, which is probably safer. And this is why, if you look at estradiol compared to conjugated equine estrogen, if you see in the right-hand side, there was higher risk of venothromboembolism, myocardial infarction, and stroke, although really the venothromboembolism was the one that was statistically significant. Next slide. And again, just looking at oral estrogen versus comparing that to transdermal, so oral, a pill versus a patch. The oral pills, either estrogen alone or estrogen plus progesterone, actually had higher embolism risk than transdermal. So for both reasons, again, if you really want to think about safety when you talk to your patients, I talk about these risks. I say, you know, the oral estrogens and the progesterones go through, there's a first pass through the liver. So again, they may be a little, have a little bit more liver toxicity, and there may be a slightly higher risk of venothromboembolism as well. So if patients can tolerate a patch, that might be a safer way to go if somebody's already a little nervous. But again, that is all shared decision-making and what might be best or might work best for your patients. Next slide. So let's go back to our case. So she finally decided she really wanted to start on menopausal hormone treatment. She did the estradiol patch and took the micronized progesterone daily. And she is so pleased because her vasomotor symptoms have almost gone completely away. So what is the normal recommended follow-up? So typically I would want to see a patient within 4 to 6 weeks after starting the menopausal hormone. And mostly that is just to see what effectiveness the treatment has had. So for example, with this patient, if her symptoms are really completely gone and she's happy, I do not need to do a dose titration. Her dose is perfectly adequate for her. However, if somebody is still having significant problems, you could very slowly maybe go up on the dose to see if you get a little bit less of the vasomotor symptoms. You do definitely need to monitor the blood pressure. You need to monitor the other cardiac risks, such as liver function tests, lipids, and of course, make sure you are continuing to do breast cancer screening, probably annually, if they are on hormones. Next slide. So let's go to case 3. A 51-year-old Black woman comes to clinic with vaginal bleeding after starting menopausal hormone therapy 6 months ago. Her bleeding is heavy and some clots. Her vasomotor symptoms have improved. She had a transvaginal ultrasound that showed an unremarkable endometrial stripe, which is one of the things we look at when there's bleeding. But does she need additional workup? Next slide. The bottom line is, yes, menopausal hormone therapy could cause some vaginal bleeding, but it should never be heavy. It should never have clots. It should never be going on for days. And my rule of thumb has always been postmenopausal bleeding must be worked up in all patients. Postmenopausal bleeding must be worked up in your patients. And ultrasound can be an initial. Transvaginal is usually better. It's optimal because it can look better at the ovaries and the endometrial stripe. But the endometrial stripe can be variable. It can also be abnormally a false negative. And even if it's thick, doesn't necessarily mean that's cancer. It just means you need more workup. So typically an endometrial biopsy is needed in women who have postmenopausal bleeding or even any serious abnormal vaginal bleeding. And it can be especially, there's data to show that especially in Black women, that the ultrasound alone can be really misleading. And so Black women may have higher risk of fibroids, and they also have higher incidence of endometrial cancer. So again, there are absolutely no guidelines that tell us that we should be monitoring menopausal hormone therapy with ultrasound. Again, we may get updated guidelines that tell us something different, but vaginal bleeding, I am really prone to wanting to work that up because I don't want to miss an endometrial problem. Next slide.
So before I go on to case 4, I also wanted to mention briefly that occasionally, as Carrie mentioned, there can be false negatives with the ultrasound. And I had listened to a recent ACP lecture on abnormal uterine bleeding, which I can provide the reference for you if you're interested. It was a 1-hour discussion. It's excellent. And the speaker talked about the ultrasound being difficult to interpret because it can depend on the axis from which the uterine cavity is viewed. He also mentioned that often the gynecologist will use a hysteroscopy or something called a saline infusion histogram to improve the accuracy of the endometrial biopsy, which can also be inaccurate. So in other words, when you get to this point, you really do need the hand-holding of a gynecologist because you don't want to miss anything. So back to my case, the case 4. So the 61-year-old now, has been on hormone replacement since menopause at age 52. She has not had any adverse effects. She's active and exercises regularly. Her vasomotor symptoms are controlled. Her mood is good. She sleeps well. She wonders if she should stop hormone therapy as she's worried about breast cancer risk. What are the recommendations? Next slide. So there are no specific guidelines as to when to stop hormone therapy. And this is according to the North American Menopause Society, because there aren't that many RCTs, randomized controlled trials regarding extended duration of therapy. The Women's Health Initiative says the risk of breast cancer, heart disease, stroke increases in the older age groups and with increased duration of hormone therapy. Therefore, groups like American College of Physicians says to consider tapering the combined hormone therapy at about 4 to 5 years. And if on estrogen alone, to consider tapering at about 7 years. The American College of Gynecology recommends shared decision-making. And with shared decision-making, you're reviewing the general health, comorbidities, any new contraindications, and then patient preference. So also think about bone loss, which recurs after cessation of hormone therapy. So if someone is at risk with osteopenia and so forth, there are clinical indicators that I can also provide for you in the references to determine if a bone density is needed and the appropriate follow-up, be it 2 or 3 years after. Next slide. What about breast cancer risk? The Women's Health Initiative showed that there's a higher rate of breast cancer in women on hormone therapy. If you go back to my slides, in the first group, which was 10,000 patient years, there were 6 more cases in the combined estrogen progesterone E plus P cohort, ages 50 to 59. But regardless of hormone therapy, breast cancer risk goes up with age anyway. About 1 in 8 American women develop breast cancer in lifetime. or another way of looking at it, the risk of developing breast cancer is about 13% during lifetime. Alcohol intake also increases the risk of breast cancer. So according to the Susan Komen Foundation, 1 drink per day increases the risk about 7%. 2 to 3 drinks increases the risk about 20%. And from looking at the data from the Women's Health Initiative, the thinking is that the increased risk of breast cancer with the combination hormone therapy is about equal to the increased risk of having 2 alcohol drinks per day if treated over 5 years, be it hormone therapy or alcohol use. So you should also consider that there is increased mammographic breast density on hormone therapy. Therefore, there's going to be a greater likelihood of callbacks and even some likelihood of biopsies. So patient may need to be aware of this. So these are our take-home points. And what we've discussed in our talk, there's a benefit of hormones that's higher than the hormone therapy replacement dose for premature menopause. There's a benefit of hormone therapy in reducing menopausal hormone therapy, reducing moderate to severe vasomotor symptoms, as well as for genital urinary symptoms and prevention of bone loss in those with moderate to severe vasomotor symptoms. It's contraindicated with known history of stroke, coronary heart disease, venous thromboembolism, and breast cancer, as well as other factors. It is optimal if started with age less than 60 and within 10 years of menopause. Shared decision-making is important if considering continuing hormone therapy after age 60. Vaginal estrogen can be considered for genital urinary symptoms if vasomotor symptoms are absent or mild. This can be continued longer term safely. And there are non-hormonal therapies that exist for vasomotor symptoms. And lastly, women with abnormal bleeding need workup. Going to our final slide, which is regarding the references. And just want to point out that you can look up the North American Menopause Society. And I tried this link yesterday with my mentee. And the second link, I wanted to show her the patient education pamphlet, and this link didn't work. So what you could do is just type in menopause.org and then type in Menonote, MENONOTE, and it'll pop up. And then under that, it will say deciding about hormone therapy. So this is what you should pull up. It's a 2-page document, and it really goes over everything that we've discussed and that you can review with the patient. And then when you have reviewed it, you can say, you know, the risks and benefits, a detailed meno note discussed with patient and so forth. Here are some of the other references we used that we referred to. Dr. Hare talked about menopause in her June 2022 talk. And these are, Manson talks about a very detailed review of the Women's Health Initiative trials and how it relates to clinical practice. This came out recently in May of this year. And then Falbion talks about the newer neurokinin blocker. And this just came out last week, a couple of weeks ago in August. And I think that should be it. And we're ready for questions and answers. I want to mention one more thing, if I may. Sorry.
There's a lot of questions, so I want to be
sure.
sure we have time to get to those.
Sure, we'll go ahead.
Yeah, let me take a few questions, and then so if you want to look at the Q&A, I'm going to go back to the chat. And all of the, somebody asked, will we get the slides? Yes, you will get the slides after you do your CME. You will have access to that. Somebody asked, what are stroke-like symptoms? Well, again, it can be anything that's like a stroke. So there are people who have really severe migraines that could actually have facial numbness, loss of speech, visual field cuts, weakness or tingling. So if somebody has serious vascular stroke-like symptoms, that may be a relative concern with using estrogen hormones. Could low-dose vaginal estrogen be an option for patients with personal history of breast cancer? Again, a lot of the oncologists will probably say, probably, yes, I am not an oncologist. And again, there's very little absorption with most of the vaginal estrogens. I don't know if there's any differences in terms of absorption, and I know Betsy will say something about that as well. But there have been women who have had breast cancer who have been able to use vaginal estrogens.
Right. And there was quite a bit of discussion about this in ACP and at the Stanford talks, and that basically there are some women who have they've had surgery and they've now on chemo, they've had chemo and now on medications like Arimidex, which causes quite a bit of vaginal dryness and dyspareunia. And these are relatively young women. Some of them are in their 40s. And so vaginal estrogen apparently can be used, but because of the low systemic absorption, but it must be with the approval of the GYN oncologist.
I would agree. I would get buy-in from the specialist.
Right.
Somebody inherited a lot of patients who are on what I would consider higher dose estrogens, and they cannot return to the specialist. So again, this is when it comes to what age are they? Do they have any other risk factors? How long have they been on hormones? At a minimum, I think what you can start doing with these patients that were placed on higher dose estrogen is to start slowly doing a taper down. And I've done that successfully with several women. I've also had where you start to taper and they may get some vasomotor symptoms again. And I usually just try to really tell them to do all the other things that are helpful, dress in layers, cool, a place to sleep and things like that. But I would try to really reduce the amount of their estrogen. If not entirely get them off of it, as we've discussed. Again, guidelines are really limited. Okay. There was somebody that says data shows lower risk of side effects. So the main question is, for that question is, if someone has a intact uterus and you are going to give hormones, you must give progesterone as well, because the risk of endometrial hyperplasia or even endometrial cancer is much higher if on estrogen alone. So the only women who should be getting estrogen alone are those who no longer have a uterus. Okay, so I hope that point is really clear. Someone asked about that you were taught hormone replacement or menopausal hormone is not recommended 5 years post-menopause. Again, the current guidelines really talk about age less than 60 and within 10 years of menopause. Someone asked, do you involve a gynecologist for all postmenopausal bleeding? And Betsy can answer for herself. Do I? Almost yes. And the main reason is because of some of the concerns with just an ultrasound alone, and I don't do endometrial biopsies in my practice. So therefore, I have to engage one of my specialists to actually complete that workup. Betsy, I don't know what you do.
When I looked at UpToDate, and it said that if, let's say, a patient was started on menopausal hormone therapy and there's bleeding during the first 6 months or so, and it's not very heavy, and it basically, amenorrhea, for instance, hasn't developed yet because of the duration of the continuous combined therapy. The UpToDate section suggested not to worry about it, but to give it some time. The gynecologists that I had consulted, a couple of them at the clinic where PAMF, where I worked, they said they have a low threshold